Welcome and thanks for joining me. My name's Nicole Hamilton. I'm a physiotherapist with a special interest in managing hip dysfunction. I'll be taking you through a few guided exercises to provide a patient following a hip arthroscopy. Remembering, of course, that this protocol is certainly not a recipe, it's just a guideline, so some patients will progress much faster and others will progress slower, depending on their preoperative conditions and their goals. So phase one following a hip arthroscopy is usually the first couple of weeks after surgery. So remembering that in the first couple of weeks there will be a certain amount of intra-articular effusion. We don't tend to push hip mobility exercises because that would just be counterproductive. I do check that the patient has comfortably 90 degrees of hip flexion in the first couple of weeks. Anything a lot less than that, and especially if they have pain, I start to be concerned about a post-operative synovitis. But if they have 90 degrees comfortably, then the rest will follow in the following weeks. Our goals for the first phase really are to manage pain and swelling, to ensure that they have a good gait pattern, so they may or may not be using crutches. That'll depend if they've had a labral repair or a labral resection. And then also to teach the basic exercises on pelvic stability activation and on activation of the hip stability muscles. And then to start to address simple activities of daily living and how to minimise load on the anterior hip during those activities. So in the first phase, it's important to teach the patient how to activate the stability muscles of the pelvis and the hip. Now, there are many ways of teaching this. I use a couple of cues, but there are many different cues you can try. Using a real-time ultrasound will also benefit, but if you don't have access to that, then there's a few methods that you can use. So Makili, I'm going to start by teaching you how to activate some of the muscles that stabilise your pelvis, remembering that your pelvis is actually the socket part of your hip, so it's going to be quite important to figure out how to activate those muscles throughout the day to help stabilise that area. So the best place to feel whether these muscles are working is if you find with your left hand this outside hip bone, and just come in about an inch or so and dig quite deep. Now this muscle wraps around and is connected to your pelvic floor and muscles called your transversus and multifidus. So to activate these muscles, everyone's brain works a little bit differently, so I'm going to try a few different ways to see if we can get this muscle to work. To start with, what I'd like you to do is to try and imagine that your two front hip bones are very gently drawing together. Beautiful, and you should feel a little bit of tension underneath your fingers. See if you can hold that tension and keep breathing. Well done. Another method that we could try is if you can imagine lifting your bladder muscles, so lifting your pelvic floor or stopping a pee. If you can lift that muscle very gently, again, you should feel a little bit of tension underneath your fingers, and see if you can continue to breathe. And then relax. And the last way we can try is if you can imagine a wire or a connection from your pubic bone into your spine here. So imagine very gently tightening that wire and seeing if you can, once that wire is tight, you'll feel some tension under your fingers and see if you can keep breathing. So the most important thing when teaching someone how to activate their pelvic stability muscles is really to ensure they're not doing the wrong thing. Most common errors that we tend to see are breath hold or oblique dominance, which we don't want, so to ensure that someone can continue to breathe. Another error that we can tend to see is posterior pelvic tilt. So if you flatten your back into the bed for me, we don't want that, and that can put a lot of extra pressure on the anterior hip, which we want to avoid. The last error that I tend to see is a butt grip or a clenching of the buttock muscles. And again, that's a common error that you can detect just by palpating. So Makili, if you activate your core muscles as we instructed earlier, I can palpate the buttock muscles and they should remain relaxed. So Makili, now that you know how to activate that pelvic stability muscle, I'd like you to start thinking about gently contracting that a little bit more often throughout the day. And remembering that muscle works very gently to hold your pelvis together. And the analogy I often use is that it works a bit like your shoelaces. So if you can imagine tying your shoelaces up, you need them tied up in the right place, but you don't need them tied up too tight. And they do support your shoe all day. So your pelvic stability muscles are quite similar in that they work a little bit throughout the day to hold your hip socket nice and stable, but they just don't work very hard. So once I've taught the patient how to activate their core muscles, they can start some very gentle core-based exercises around the hip from week 2 to week 3 onwards. I do like core exercises to be closed chain, so the legs can either be supported on a ball or on a reformer or with some band, which I'll illustrate later. But Makili, if you can gently activate your core muscle the way we instructed before, imagine your thigh sinking into the socket so this muscle here stays nice and relaxed. And keeping that core muscle active, can I get you to roll your legs out with the ball and then back? So that's just a gentle hip range of movement exercise that we can be starting at phase 2 or late phase 1, which will involve core activation, hip centering, but in a closed chain way so that the hip is supported. So another method of closed chain core exercises that you can use for the hip is by grabbing some TheraBand or TheraTube, but fairly high resistance, so blue or green preferably. And Makili, if you can activate your core muscle very gently, and again, try to imagine that your thigh is sinking into the socket so that this muscle here, the TFL and rectus femoris, remains soft. And keeping that connection, can you lift your leg just to 90 degrees? And with your core engaged, can you extend the leg away and then back? So this is another Pilates-based core exercise for hip stability that can be started in the early stages, again, because it's closed chain and the hip is supported. So the other part of stability training in the early phases or the early weeks following a hip arthroscopy is not just learning about the pelvic stability muscles, but also about the hip stability muscles. So one of the important muscles to learn to activate is the quadratus femoris. To palpate quadratus femoris, you can come from the ischial tuberosity. Just a little bit superior and lateral to the ischial tuberosity is where quadratus femoris lies and where you can palpate in order to teach how to activate and isolate that muscle. So once you've figured out where to palpate quadratus femoris, in order to teach the patient to isolate and contract this muscle in the early stages, I normally get them in side lying with their hips and knees flexed to about 50-60 degrees. I try to make sure that they're not tucked under, so Makili, if you can roll a little bit forward of your buttock and stick your bottom out. Yeah, that's it. Because we don't want to encourage posterior pelvic tilt. So palpating QF, Makili, if you can pop your own hand just onto that part of your buttock quite low. And what I'd like you to do here, if you can, is to imagine a line from your knee into your hip and very gently drawing your hip into the socket gently. Hold that for me, but just make it gentle. Now can I get you to very gently squeeze your heels together and hold that for about 10 seconds, and you'll feel a little contraction or tension under your fingers. And hold that for 10 seconds and then relax. The important errors to avoid with this are an adductor squeeze, so make sure the knees aren't squeezing together. Make sure they don't contract too hard because then they'll just grip everything. We want to try and isolate it to QF. So just a gentle heel squeeze, 10 by 10 second holds in the first couple of weeks will help to start activating the hip stability muscles. In the first phase, once you've taught the patient how to activate the hip and pelvic stability muscles, the next and probably the most important thing I feel is to start addressing their habits of daily life that can add to additional load onto the anterior hip. So educating the patient on how to minimise the load through the anterior hip is most important. So I start by initially addressing just simple standing posture. So looking at the patient, I always use a mirror so the patient can see what's going on. So starting from the feet up, looking at the knees, if the patient has the tendency to knee hyperextension, that can place additional load onto the anterior hip by throwing the femoral head in the anterior direction, which we don't want. So if you've got a patient that has the tendency to hyperextending of the knees when they're standing, they need to be educated on to maintain as often as they can their knees soft. The next thing that I look at in the basic plumb line of keeping the femoral head centred is the alignment of the femur through to the ankles. So very commonly patients with labral tear will present with a habitual standing posture of posterior pelvic tilt, anterior sway, which essentially means the greater trochanter is going to be well anterior to the lateral malleolus. So if they have gone to the trouble of having surgery on their hip, and then spend the next 6 weeks to a year standing this way, they're going to have ongoing problems with their hip. So really important to educate, can we try and make sure that, Michaela, you keep a little bit of weight through your heels if you can, so the toes are soft and relaxed, and that the greater trochanter is lined up roughly just anterior to the lateral malleolus. The next section that I look at working up the chain is the thorax. So Michaela, if you would just want to pop your hand just on the centre of your sternum, so manubrosternal junction, and just above the pubic bone, so a little lower. Yeah, just down here, yep. So if the patient has a tendency to have their thorax posterior to the pelvis, which will often go with that anterior sway, again, that can place anterior force on the femoral head into the anterior part of the acetabulum, which will only place load onto the labrum. So the instruction would be, Michaela, if you could imagine just a little hook or a wire gently pulling your thorax up and forward so your body can stack itself and that you don't have excessive load onto the anterior hip. With instructing a person on how to stand, I try to pick 1 or 2 key problem areas. I never give someone 6 instructions on how to stand. It's often too much to remember for anyone, so just 1 or 2 key instructions. So another thing that I can look at in standing posture is the alignment of the pelvis. So placing the hands just on the 2 front hip bones, Michaela, so the ASIS, they should be pointing in a straight anterior direction. I do have occasions where you'll have a patient that habitually will be twisted to the left or to the right, which again will throw the femoral head in the anterior direction. So the instruction that I would give with this is, if you can imagine, Michaela, that you've got headlights on the fronts of your hips. When you're standing throughout the day, cooking or in the supermarket, try to ensure that your 2 front hip bones are pointing straight ahead, and that will make sure that your femoral head's not pushing up against your labrum. So once I've spent some time analysing and educating the patient on how to stand correctly to minimise the load through their anterior hip, it's here that I also start to form some ideas about what kind of manual therapy I might need to provide to the patient. For example, if their thorax is posterior to the pelvis, and we try to correct this and stand in a better posture to offload the anterior hip, and they're having difficulty with that due to restriction through their thorax, I'm starting to think that I might need to provide some manual therapy, some home stretches, or some mobility-based exercises in order to improve that thoracic mobility so that standing in correct alignment is not so difficult. So of course, as well as standing postural alignment, we also need to address how the patient is sitting in order to minimise the load through the anterior hip. It's always advisable, especially for the first 2 to 6 weeks after surgery, that they don't sit on excessively low chairs, so keeping the knee below the hip is probably recommended. But in order to allow and ensure that the femoral head remains centred during sitting, and this is especially important for the butt gripper group of hip patients. So Michaela, I'm going to teach you how to sit, and the best way for me to teach you is to actually teach you how not to sit to start with, and then you'll feel a difference between good and bad sitting. So can I get you to here, just clench your butt cheeks together, tuck your tailbone under like you're tucking under a skirt, and sit down. So this is excessive tension in the posterior part of the hip that can restrict the posterior glide of the femoral head, which should happen as we sit. And over a period of time that can add to load on the anterior hip. The other downside of this sitting posture, of course, is that it will contribute to slump, which is not great for the core or the lower back either. So that's how not to sit. So can I get you to stand up again? So to sit correctly, Makili, what I'd like you to do is to relax your buttock muscles. Imagine you've got a skewer that runs from one side of your hips to the other. And can I get you to fold through that skewer with your bottom wide and sit down? And then if you can also, if no one's looking, place your hand underneath your butt cheek and just separate your buttock and separate your sitting bones gently. That will reduce the tension in the posterior part of the hip and allow the femoral head to glide posteriorly as it should when you sit, which will help minimise the load through the anterior hip. So phase 2 following a hip arthroscopy is roughly from about week 2 through to about week 6. And it's in this phase that we want to start to gradually increase the hip and pelvic stability exercises to improve dynamic control around the hip. We also, most importantly, want to start to address the underlying reasons that the patient has presented with labral tear and gone through the process of having surgery for their labral tear. And the reasons will be different and unique to each patient. So I'll just run through a couple of things that I tend to look at in order to steer and guide my manual therapy, unique and specific for each patient's presenting problem. So once we get to phase 2, what we're doing is starting to address the underlying biomechanical reasons that your patient has presented for surgery for a labral tear. And now, of course, remembering that there'll be a certain group of patients that have had an acute injury or an acute trauma whereby analysing their biomechanics may not be relevant to them. They may have no predisposing factors, it was just an unfortunate accident. However, the large majority of patients that I see that have surgery for a labral tear are patients that have had a gradual, insidious onset of symptoms related to biomechanical overload on their anterior hip. So it's about, in phase 2, trying to figure out why has that happened and can you address some of this to prevent them getting worse down the track. So the typical things that I look at, firstly starting from the feet. Your feet are essentially designed to be springs, so the first spring when you walk and when you run. And if someone has a particularly rigid foot, supinated foot, toe gripping, tight talocrural joint, old ankle sprains, this can be one of the reasons that you have excessive load onto the anterior hip. So I do check the patient's foot and provide manual therapy if required in order to ensure optimal foot alignment and control to minimise the load through the anterior hip. So then working up the chain, of course, muscle imbalance around the hip is another contributing factor to excessive load on the anterior hip joint. And again, that will guide your manual therapy, but typically we see hypertonicity in TFL, rectus femoris, and also sometimes the deep posterior hip muscles in some patients that are butt grippers, such as piriformis and obturator internus, with also deficiency in stabilisers in the posterior lateral hips, such as quadratus femoris, lower fibres of glute max and glute med. So muscle imbalance around the hip can certainly add to load on the hip, which means that in this phase you'd look at some manual therapy for the muscles that are hypertonic. Manual therapy could include massage techniques or trigger point release. So working further up the chain to address some of the predisposing factors that can contribute to anterior hip load, also looking at any asymmetry in either motor control or compression around the pelvic ring. So you may at this stage in phase 2 start to provide some manual therapy for either the pelvis or the lumbar spine. Of course, if we have asymmetry in the pelvic ring in either control or compression, it can contribute to pelvic torsion or a twist, which can place load onto the anterior hip. And then working our way up the chain then to the thorax. So as I suggested previously, if the thorax is posterior to the pelvis, it can certainly contribute to excessive anterior load on the hip. So the patient might need thoracic mobility exercises or thoracic release-based work or manual therapy. If this is the case for your patient. Also, not only with the thorax being posterior, but we can also look at thoracic mobility, which should be even and symmetrical. If there's any asymmetry in thoracic rotation, it can place additional load onto the hips in activities of daily living. So the manual therapy that you provide for your patient in phase 2 following a hip arthroscope is actually going to be quite unique and individual to each patient, depending on the predisposing factors that have contributed to their labral tear. So you might look at mobility, stretches and manual therapy to the foot, addressing muscle imbalance around the hip, muscle imbalance or excessive compression around the pelvis or lumbar spine, and also the thorax. And these are the areas that I would normally assess in each patient individually. Looking at now hip and pelvic stability exercises starting from about phase 2, I like to use functional based exercises, so feet on the floor. I use normally a little band around the knees to encourage glute activation and hip abduction, external rotation, but just a light band, it doesn't need to be very strong. A little roll towel under the heels does help if people have got very tight ankles. It's not necessary, but it can assist. So starting in standing, Makili, starting in sitting, can I get you to gently activate your core, nice and tall? Can I get you to fold forward through the hip, push through your heels, keep your knees out to stand up? And then folding at the hips and bottom stays wide, keep the weight on the heels and squat for me and then come back up. So teaching a basic squat pattern is a good exercise in the early phases, just not too deep, so just continue for me. The main common errors that I see with this are too much weight on the toes, knees rolling in, which will tend to activate TFL and adductors. So keeping the knees out into the band and the weight on the heels is important. For someone whose thorax tends to be posterior, they'll really struggle keeping and maintaining their thorax forward. So sometimes we might need to encourage, can I get you to take your chest a little bit more forward, stick your bottom out a little bit more as you fold forward at the hips and squat. So starting with a very basic squat, just not too deep in the early stages of phase 2 is the beginning exercise I would start with. So progressions of a basic squat, moving into a split squat, so taking the unaffected toe back and keeping it relatively light. You don't have to have a chair there. Sometimes I find patients need a chair to figure out how to get good technique, but it's not essential. So again, same as the squat, Makili, can I get you to fold through the hips, stick your bottom out like you're sitting in a chair, keep your knees out into the band, push through your right heel to come upright, and as they push through the heel, I start to get activation through the posterior lateral part of the hip. So working at increased repetitions, starting with a basic squat, moving to a split squat is my next progression. So once the patient has managed squats and split squats with good control, over the next few weeks you can then progress to what I would call a sumo squat. So again, starting in standing, making sure standing postural alignment is accurate. A little roll towel under the heels is not essential, but if someone's got tight ankles, it can help. So Makili, can I get you to fold at the hips, stick your bottom out like your squat, keep your knees a little out into the band, take your right knee out into the band, and then transfer your weight onto your right heel, lifting your left hip just a fraction. And let's see if we can hold that for 3 seconds. Keep your right knee out and then come back to the center. So that's what I would call a sumo squat. We can work at increasing holds and increasing repetitions. I do keep the left or the unaffected side on the ground so they can maintain good alignment to start with. But this exercise will help to start build on gluteal control. So another exercise that can be introduced in phase 2, especially if someone's having trouble with squats or if they have signs of very poor stability around the hips, such as weakness through their quadratus femoris. You can do a simple squat against the wall with a ball, and you can, Makili, what I'd like you to do is to palpate that muscle that we discussed before. Soften your knees a little bit, and can you create some tension in that muscle to start with? So a little bit of tension under your fingers. Now going down into a squat for me, so bend the knees. And then push through your heels and you'll feel your glutes work to push you up. So a very gentle amount of tension in the quadratus femoris to start. Maintain that tension as you lower. Then push through the heels in order to come up and your glutes will naturally activate. Now, common mistakes with this exercise, again, is watching knee position, pushing too much through the toes, and ensuring that the lumbar spine stays neutral, so not tending to excessive lumbar lordosis or posterior pelvic tilt. Once you've managed squats and lunges over a period of a few weeks, you can start to add some weights if it's appropriate for your patient according to their pre-operative status and their goals. Another exercise, which is a progression toward the end of phase 2 and early phase 3, is a step up. So Makili, if you could just hold onto the wall very lightly, have the affected leg up on the step and the other leg back. Can I get you to fold forward almost like you're bowing to a crowd? Push through your right heel and lift your left knee up and you should get a nice glute activation. Fold forward again to come back down and just tap the floor with your left leg and then push through your right heel and come back up. So just do a few repetitions there for me. Common errors with this are knee coming inward, which would overload TFL and adductors. So we want to make sure that the knee's out. Keeping pushing through the heel rather than the toe, which will bias the glutes rather than the quads. And also ensuring that the thorax goes forward enough, which again will encourage a glute activation. So phase 3 following hip arthroscopy is roughly from about week 6 to week 12. In this phase, what we're trying to do is continue on treating with our manual therapy to address any of the predisposing factors to labral tear individual to your patient. And of course, at this stage now, we're starting to build on weights and also challenge proprioception with some proprioceptive-based exercises depending on your patient's goals. So working now into phase 3 exercises, more challenging exercise of sumo squat is with a band. So Makili, again, keeping the weight on your heels as best we can with a roll towel if needed. Going into a quarter squat for me. And again, like the sumo squat, you're going to take your right knee out into the band, transfer your weight to your right heel and lift your left foot off the floor, ensuring that the pelvis doesn't drop. Take the foot out into the band and back. And just do 3 or 4 repetitions. Yeah, 2 and 3, and then have a break. So sumo squat with a band is just more challenging dynamic hip and pelvic control. Common errors are too much weight on the toes with toe gripping, knees coming in, which we don't want. Keeping the knee out into the band is important. So I tend to just do 3 or 4 repetitions to ensure that they have correct alignment and good control, and start to build on that. So again, to build on proprioceptive challenges in phase 3, depending on your patient's goals and their capacity, you can introduce things like air cushion or spin discs or something like a Bosu ball with their squats. So do you want to start to do a few of your squats? Keep your core on. Now you can have the band around the knees if you want to for this exercise, depending on your patient's hip control. So starting with quarter squats, you can also step off and do your lunges or split squats in this position. So come off that step and pop your right foot in the centre. Yeah, and up on your back toe, and then going to a lunge or a split squat. So again, both of those exercises can be done on something to challenge the balance or proprioception. Thanks very much for joining me, and I hope some of these clips have helped you assist your patient with their recovery following the hip arthroscopy.